So welcome. I know that this is a busy time and a difficult time for some people, and very much appreciate your joining this webinar and really acting as a community that's working together to confront the COVID pandemic. So what we're going to do today is I'm going to make, this is Miriam Rabkin, sorry, from ICAP at Columbia, the PI of the CQUIN network. What we're going to do in this call is have a very demand-driven webinar. So the idea for this webinar series and the design of this webinar series have very much been formed by the needs and requests and interests of participants in the CQUIN network. So this is not intended to be a scientific update or even really an epidemic update. It really is an attempt to bring people together, so colleagues who are working in different countries around the world to confront the pandemic, to bring us together to exchange practical experiences. A lot of us are facing, no matter where we are facing an epidemic without enough information, without enough tools, and part of the beauty of this network is the ability to ask questions in real time to get help from people in other countries who are, facing the same challenges of having to make important decisions without enough data or having to redesign systems. So I'm going to make some brief framing remarks just to sort of set us up. And then we are really thankful to our Ministry of Health colleagues from 3 countries who are taking time out of their extremely busy schedules to give us a brief update. I also wanted to thank Dr. Catherine Godfrey from PEPFAR, who is going to give us a brief update sort of from the PEPFAR perspective. And then we really are going to aim to have about half of the time, depending on timing control, a lot of time for questions and answers. This is intended to be the first in a monthly series of webinars that we're going to host for the CQUIN network in partnership with the International Treatment Preparedness Coalition and the International AIDS Society and other colleagues. And we're going to, build the boat as we sail it. So different weeks will focus on different topics. I think next week, one of our topics will be the issue of procurement. But if you have questions, comments, suggestions, please share. So I don't think I need to do much convincing of the relevance of the COVID epidemic to our CQUIN network. So I heard that just 10 minutes ago, Sierra Leone had its first official case, which brings us to 100% of the CQUIN network countries reporting known cases of the novel coronavirus, and clearly there's a huge number of unknown or undiagnosed cases at this point. But I did want to focus us on the intersection of DSD and the COVID epidemic. I also want to acknowledge that countries are in sort of different stages of the epidemic. WHO has this categorization sort of four stages. So one would be a country that has no cases, which was Sierra Leone until 10 minutes ago. Other countries have sporadic cases. Other countries have clusters of cases, and then countries like the United States and others have community transmission. And clearly the response is going to be different in different stages, but the strategic planning probably will be the same, or the way countries are approaching this. So this is a document from WHO, which talks about 8 pillars of the response. I'm not going to go through them all. I just wanted to sort of indicate that there is organized guidance about how to strategize, how countries might want to prioritize activities in response. This is another way to think about strategic planning, sort of important steps. So there's recommendations for every country to activate an emergency operations center, to try to understand the real-time spread of COVID-19 in your community, clearly to slow and reduce transmission, focus protection on high-risk groups, reinforce and expand surge capacity if possible, expand risk communication and community engagement, and then attempt to mitigate economic and social consequences. And so one of the things that we're going to try to focus on in this discussion is how can DSD help? Another way that I think sort of this is sort of my perspective on what are our immediate priorities, and a lot of them have to do with protection. So we need to protect our frontline healthcare workers. We need to protect recipients of care and patients at our health facilities. We need to protect communities. We need to protect our programs, right, in a way. So HIV and TB programs, we can't redirect all of our resources towards the immediate threat. And there needs to be strategic planning about how to, as best we can, continue to achieve our medium and long-term goals. And then clearly we need to protect health systems as a whole. So it's quite easy to connect the CQUIN network and the COVID epidemic. The relevance is clear. Connecting DSD, I think, is also quite easy for many of us, and there's been a lot of exchange and on the WhatsApp group, but thinking about what does DSD specifically have to do with the COVID response? And so some of that has to do with adapting our existing models to protect recipients of care and healthcare workers. So decreasing contact with health facilities, and there's been a big push to multi-month dispensing, not only for ART, but for other medicines as well. So certainly there's recommendations in many countries to do this for TB preventive treatment, for TB treatment, for other non-communicable and chronic diseases, to empower people to spend less time at health facilities, both for their own protection and to decongest health facilities for the protection of healthcare workers and the health system as a whole. We'll talk more about this, I think, but the sort of approaches to multi-month dispensing are a little variable from country to country. So some countries are moving quickly to 6 MMD, others are staying with 3 MMD, but relaxing criteria. So suggesting that you don't need to have been on ART for 6 or 12 months and have a suppressed viral load in order to be eligible for MMD, to say that anyone who wants to can have that is one a direction that some countries are taking. Other issues include assessing our current DSD models to think about their risk. So for example, Eswatini has suspended its teen club model because it didn't think it was safe for the teens to aggregate in that way. In other countries, there's been more of a move towards integrating social distancing into DSD group models. And then the other sort of key theme that's been coming out in our discussions is the ability to leverage these DSD models, in particular community ART groups and other community models, to empower recipients of care and communities. So these recipients of care who are enrolled in these models are experts at self-management, they're experts at sort of solidarity and supporting their group and their community, and giving them enough information about the novel coronavirus, about recommendations for infection prevention and control, about when to go to health facilities and when not to do so, is an important connection with DSD. So we'll hear more about that. In response to the COVID epidemic, we really did pivot our learning network to focus on the needs and questions that are coming up from the group. So we combined all of we had WhatsApp groups for each of our communities of practice. We combined them all into a big sort of CQUIN COVID WhatsApp group, which now has about 120 people. There's been lots of really helpful exchange and questions and sort of country A sharing tools and resources and decisions with country B and vice versa. We also shared a Dropbox folder for tools, guidelines, and resources, and there's been a lot of really great stuff coming from the International Treatment Preparedness Coalition, IAS, the differentiatedservicedelivery.org website also has great resources, the African Society for Laboratory Medicine. So these are our existing learning network partners. We have also updated the CQUIN website with resources, and obviously we started this webinar series. So today we had planned a panel with representatives of three ministries of health and OGAC. You may notice that there's some imbalance in this panel. And you might think I'm talking about gender imbalance, but actually all four of these presenters' names begin with C. So we also have alphabetical imbalance. And I coincidentally just learned like 4 minutes ago that Cordelia Kateribi is swamped from Uganda, so I believe that Dr. Josen Kagundu is going to present in her place. So that solves both of our imbalance issues. And I'm checking to see if Josen is on the line. Laura, do you know if Josen has joined us?
I don't think Josen has joined just yet.
Okay, so what we'll do is we'll just switch the order and start with Dr. Kateribi. So Kate, I'm going to unmute you in a moment. Catherine Gugi, who's going to speak next, sorry if I got that, if I'm mixing up names, is from the National AIDS and STI Control Department at the Kenyan Ministry of Health. She'll be followed by Clorato Gwanzura from the Zimbabwe Ministry of Health. And then if Josen has joined us, we'll hear from Uganda. And if not, we'll talk to Katie Godfrey from OGAC. So Kate, we'll give you about 10 minutes to get an update from Kenya. Thanks so much.
Okay, great. Good afternoon. It's Kenya, it's afternoon time. I don't know the other timings of the other people in the other country. My name is Kate, and I'm the head of the division of NASCO in Kenya. And I'll take you through a brief, like 5-6 slides on what we are doing in these tough times, calling them tough because they're very tough on us. Next slide. So we had our first case around 13th of March. So far, as by yesterday, we had 50 confirmed cases. We had 1 recovery and 1 death. We have been, the people we are following up around 1,211. And then within, and those ones that we have are within like the 7 counties within the country. Now, most of them, the cases definitely were either they had traveled or they had got in contact as what is happening in all the other countries outside. Next slide, please. So, as any other country, you know, the measures that are being given, you know, to mitigate what we have is social distancing, hygiene. What did our government closed all the schools and institutions. They banned all international flights from last Wednesday. And then we had closure of all places of worship, bars, restaurants, and any takeaway bases. We are on partial lockdown, not yet total. We have had bans as well on social gatherings, inaugurations on our transport industry. For example, if a matatu was doing 14 people, it's doing only like 6-7 people now. And then we have a curfew now from 7 p.m. to 5 a.m. in the morning. Now, we started from yesterday testing people now who have been on quarantine. We have almost like 2,500 people who are on quarantine in several hotels, institutions. We have them in the whole, within Nairobi. The people who are jetting in, that we were putting them on a mandatory quarantine. So we're starting to test now, and then the ones who have comorbidities, we have been taking them, like for example, to facilities, health facilities, so they can take care of them. But as well, we have had people who have been taken to quarantine because either the neighbor reported them or they felt like they traveled and they were not sincere to open up, that they needed to take, they were not doing the self-quarantine, adhering to it. Next slide, please. And so, how are we within the context of DST in Kenya? And I think for us, we have 1.3 million people who are people living with HIV and around 140,000. We have 1.2 million on ART. So one of the things I think we released a guidance, I posted it in the group. So we had to decongest the facilities. So we had been using the 3 multi-month dispensing, but you know, those people fill the categories. But this time now we ensured that despite your viral load, we were giving you 3 months, but still you are open to ensure that we decongest our facilities, one, but then at the same time to ensure that we do not put you at risk knowing that you are immune compromised. And then the risk of transmission to healthcare workers, you know, to ensure that we decongest. Those are the considerations that we had when we were making that guidance. And then the possible, you know, of diversion of healthcare workers. For example, right now in the Ministry of Health, all the HIV program activities have been, not only HIV, even TB, any activity has been put to a halt. So as we can at least stabilize, especially the ones who have been put in, quarantine. For example, like me, I am overseeing almost 9 hotels. And we are running, I'm the one who is coordinating the call center for the healthcare workers. We have 2 call centers whereby one is for the public and then the other one is for our healthcare workers. And then commodity security, I think it is a worry for most of us. Like we did an assessment to look to see what do we have in the facilities and what do we have in our stores before we made the decision of ensuring that we issue the 3-month and multi-month dispensing. And I advised several of you who came to me, like, how did you make that decision? Because we know even, India has halted in terms of supply, or the other countries we are getting the supply from has really had issues with. Next. Now, when it comes to, Miriam, let's go to the next slide, please. The circular that we released, then the key changes that we did and recommendations in the context of DST was we recommended 3-month multi-month dispensing of ART, regardless of their age and viral status. We promoted the CAGs a lot to ensure that we reduce that facility congestion. The client flow, to ensure that the triage is, we advised our healthcare workers within the facilities and how to go about it. Issues to do with the visits during the day, we have ushauri. Ushauri is whereby someone can call and ask, like, they don't have to come to the facility. Maybe whatever they wanted to be sorted out or advised on can be done through the phone. And we have a free call line within NASCOP that people call and they're able to be advised on what to do next. So people do not have to go to the facilities. Then we have the weekend adolescent. Their sons are still ongoing, the weekend and adolescent clinics. Now, we have really promoted self-testing and have ensured that our facilities have had 3 months commodity security of HTS self-test kits within our public to ensure that we promote that, because we do not want to have clients coming in and, the exposure and the risk of transmission. Facilities, they have, what we did this, when they gave their orders, they gave their reports by the 10th of March, we gave them 2 months, when they ordered, we gave them 2 months extra of ART from KEMSA. And then most of other chronic illnesses like TB and guidance as well, they did the same guidance that we did to ensure that we have multi-month refills. But like when it comes like when clients have to be observed, like for example, in methadone and as well in TB, some areas, we are still a bit hesitant, but at the moment we are making other changes and other guidance are in discussions right now to ensure that we have our clients taken care of, but at the same time, we do not have our facilities congested, and protect them and protect our healthcare workers, so they can have as many people healthcare workers concentrating on COVID right now. Next. This is just a snapshot of what we have developed so far in the country, and I think I have already posted in the main group. I'll go to the training package. I think the rest people can read through. We have developed a 2-day training package whereby we have almost 14 thematic areas that we are teaching. The counties, healthcare workers, and even we have employed newly 50 doctors to man our call center. And so, and as well, we are utilizing the ECHO platform. We have a morning sessions and afternoon sessions, whereby we have almost 3 people who will be logging in, and we take them through in terms of like case management and how to social tracing, how do you do IPC, how do you do activate your response team, and many others. So, and we are willing to share that whoever feels like they can really utilize it in the country, or even customize it to your country. But I think the other SOP messages and protocols, I think people can go through them. Next. I'm trying to keep time, Miriam.
Yes, you're doing very well. Thank you.
And then educational materials. I think this one I've shared in the group, which it's not only us, I think all the other countries. We are trying as much as possible to ensure that we cover most of the health areas, all the morbidities that we have. So as if the healthcare workers, because now we are moving from Nairobi, we are having the counties now recording several COVID positive cases, that they know what to do. As I've said there before in your presentation, Miriam, we have EOC already activated. We have several free toll lines where people are using all over the country to ensure that if you have an issue, event reporting or mental health issues, or you want an ambulance, that we are utilizing. Next, and as I finish, So to me, main areas ahead for the group and to see what other countries are doing. Yes, we are doing 3 MMD, but within the context of pediatrics and adolescents, there's a need for regular dosing adjustments. How do we go about it? Especially we know that looking at side effects, looking at the tolerability and the potency, which we are having issues with. As you know, Kenya, we have had viral suppression of our children was not doing so well. We were around 68% in terms of Kenfia. It's an area that we'd really like to improve on. That any data out, especially do we have in cause of COVID-19 in TB patients and PLHIV? I know what we have so far, we don't have any direct correlation between the two. And then any emerging issues, malaria cross immunity, we are really thinking through about it and wondering, like in Africa, we have not had so many deaths or this that we're having to as we move on, that we record more and more. But anyway, this is a very great platform. We want to say, first of all, thank you very much to Miriam and the team in CQUIN. The WhatsApp group has really been very much of help so that we can be able to learn from each other and be able to know how to give best to our countries and as our patients. Now, in terms of HIV program, at the moment, I know we have held back a little, but I know we are starting discussions right now with the UN family and the other key stakeholders within the country to ensure that we do not forget, we don't reverse the gains that we have had over the years, and ensure that as well they're taken care of. Because if you go there, you're going hoping, okay, not really hoping. Unfortunately, we do not know how this is going to last. Doesn't mean that come another 2 months, I'll start issuing another 3 months, of supply. And we do not have enough in our stocks. Those are the questions back in our mind. Back to you, Miriam. Thank you.
Great, thank you so much. And we're going to have a few more presentations and then we'll take questions. But I just wanted to really admire not only your time management, but also the great work that Kenya is doing and the real generosity of sharing all these tools and resources. Our colleagues in Uganda are having network difficulties. So we're going to go to Zimbabwe next. And ask Clarata Gwanzura to present on behalf of the Ministry of Health and Child Care. And in Clarata's defense, we did not ask anyone to develop slides. So we really just asked Clarata to focus on 3 questions. One is, as Kate has done, what are some of the decisions and policy choices that Zimbabwe has made related to DSD? What are some of the, are there resources, tools, and other things that Zimbabwe has to share? And what are some of the questions or needs that Zimbabwe has for the rest of the group? So Clarata, over to you. Okay, so we will see if we can connect Clarata for an update from Zimbabwe, but now we'll move to Katie for an update from PEPFAR, NOGA.
Sure, and thank you very much, Kate. I've been really impressed with the response of the Kenyan government ministry, and I've found the materials that you've posted on the chat extremely useful. We're having really lots and lots of conversations about how programs need to manage in the setting of COVID. I will say that PEPFAR remains deeply committed to controlling the epidemic and providing prevention and treatment services in the context of COVID. I mean, just to remind everyone, PEPFAR supports more than 15 million people on treatment in more than 50 countries. And we remain committed to ensuring access to services for all populations, including the most vulnerable and at risk. I think we're doing the best we can, really making a decisive action, really, to try to protect the investment. I think that the overarching principle that is really the most important is really to ensure the continuity of ART, to accelerate the decongestion of healthcare facilities, and in order to minimize transmission of COVID-19 and to protect the recipients of care with HIV. And we think that the critical intervention for all programs and individuals is accelerated scale-up of multi-month dispensing. And we really promote decentralized services where possible for treatment and prevention. So that's kind of the overarching principle, and I believe that you know, some of the we've been putting out guidance basically twice a week that really reflects some of the principles, trying to actually mobilize the networks of both of academics and program people and technical experts within OGACT in order to try to figure out what the best guidance possible is. We do operate in partnership with host governments and under the Chief of Mission Authority, and we are encouraging the country teams to work very closely with national governments to put out temporary changes in policy. They may well be temporary, that will allow uninterrupted essential HIV services to clients while minimizing the interaction with healthcare facilities. We are supporting leveraging virtual approaches, use of social media, phones, SMS, any other forms of communication. And as I mentioned, we're delivering targeted guidance twice weekly to all PEPFAR programs. Currently, we're working through the details of trying to figure out how to what kind of guidance we can give for patients, people with tuberculosis. And, you know, it's just, there's no good answer. There's just no good answer. And so, you know, I've found that this forum is actually very, very helpful in sort of seeing what other people are doing and working through the details of what other countries and what other programs, what guidance has been given by other countries. I'm very happy. I've posted our guidance on the various on the forum, but I'm very happy to answer any questions about what you know, specific topics in the guidance, and if there's anything that you'd like that this forum would like us to kind of to produce, I'm happy to do that too. As I said, I think that the current we are expecting that there will be significant diversion of human resources, that healthcare workers will be really pulled from HIV services to provide care for individuals with COVID, and I think it's really I think, given what we have seen in the larger cities in the United States, the experience of individuals in Asia and in Europe, I think that, and the projections of when the epidemic will likely hit the African subcontinent, African continent hard. I think that any preparation that we can do ahead of time to sort of clear the decks, I think it will be very, very useful. The projections that I've seen really look at sort of a mid-May, early to mid-May peak of or exponential rise of COVID cases on the continent, which is extremely sobering. And you know, and the reality is that we don't know the interaction between HIV and COVID-19. This is not information that we already have. We don't know, and we don't know the how some of the other comorbidities will interact with individuals with COVID-19. These are all things that we are learning and trying to figure out as we go along. I can stop there and take questions, Miriam.
Yeah, I think so. So thank you, Katie. I think that, you know, your availability and responsiveness have really been extraordinary and a huge help to the group. So what I'd like to do is I'm going to call on a couple of people for additional comments and perspectives. But in the meantime, if you could type your questions in the chat box, we'll do that. And then can have, there are a lot of experts on the line. So clearly you can direct questions to our two presenters, both Katie's, Kate and Katie, but also ask more general questions of the group. And if Clarada reconnects, we will have her present. And if not, we can hear from Zimbabwe and Uganda next week. So I wanted to start by asking Anna Grimsrud from IAS just for her perspective, both from IAS and perhaps maybe give a little update about South Africa, not an informal update.
Thanks, Miriam, and hello to the other 75 people on the call. And thanks very much to Dr. Cates for those great presentations. Super, super interesting. So gonna speak a little bit off the cuff here, but obviously we have been engaged in a number of conversations and super grateful for all of the sharing that's going on the WhatsApp group and through other various forums. I just wanted to reiterate Miriam's point in the opening regarding stock and supply chain and giving out longer refills, and say that, you know, for many countries, we hopefully are not anticipating stockouts till Q3 this year based on forecasting before COVID-19. So hoping that on some of these webinars and other platforms, we can hear from some of the people that do track and follow global supply chain and work with the various partners who know more about that to make sure that we are dealing with accurate information there. Also wanted to kind of iterate another point that was raised around children, and just to make the case that for children who are 2 to 5, WHO still says that they can receive 3-month supply. And I'll highlight a viewpoint that's coming out tomorrow with a few of our PEPFAR, CDC, and USAID folks about that. Also kind of make the call to the group, maybe to Dr. Kate from Kenya, but also to the other countries on the group around what materials are available at the moment for primary healthcare facilities in regards to what they need to do to ready their facility for COVID-19. So we know that there are examples from Ebola and other emergency responses, but would love to see the specific COVID-19 guidance in that way. That's something that we're being asked for in South Africa. And then really as well around longer supply chain, not just for HIV, obviously, but also for TB patients. And you'll see some of the guidance that's been drafted around that by various TB partners, but as well as emphasizing the potential opportunity to support longer acting contraceptive methods. Helen would want me to speak up about that and also feel strongly about that. And then finally, a point to all of you that we're really interested in is around how we can ensure that there is community monitoring and reporting of stockouts, of facility readiness, of incidents at facility level, be they not able to access the refills that they're supposed to or not accessing the quality of care that they need, as well as ensuring that our healthcare workers also have the ability to report what's happening at the level of facility. So we'll be interested to hear more about that from all of you at the call. From South Africa, we are obviously, as Miriam's heat map showed, in a slightly different place potentially in the COVID-19 epidemic response here. We've been in lockdown since Friday and are still kind of learning how to do lockdown and learning how to ensure that our essential staff, including nurses, can be able to get to work in order to support the healthcare system. So hopefully some early lessons for all of you. At this stage, we really are advocating with national government to ensure that they can put out guidance to support 3-month supply. Our understanding is that this is currently sitting with the Affordable Medicines Unit, and that following national guidance, we hope that we can have some national communication of the stock available by regimen. So in South Africa, we've been a little bit slower to transition people to dolutegravir-based regimens, and so know that we may have more stock of those regimens available than of some of our other stock. So really wanting to make sure we have up-to-date data available on stock. And I'll pause there, but yeah, like I said, any resources on how primary healthcare facilities can ready themselves would be super interesting, and I think something that we're keen to support in terms of everyone getting ready. Thanks.
Great. And then I noticed that Lillian DeSecco from the South African National Department of Health is also on the call. If you can unmute, looks like you're unmuted. Did you want to add anything, Lillian?
Not at this stage, except to say we do have a teleconference that I'll be joining in 5 minutes with Affordable Medicine, addressing the issues of stockouts and also to clarify the issue of 3 months supply. But suffice to say, we are on lockout, and so far our systems are holding on in terms of the patients collecting medications at the points that they are supposed to collect on, because services are essential services. So patients are still allowed to go to clinic and collect their drugs, those that were due. But I must also say, because we've got our differentiated care already having kicked in, it's only the patients that were due for their refill that are going in for the refill. The chemists that we used on CCMDD still have their stock, and they are issuing and they are opening during the day, the usual time. So we've had very few complaints of shortage of drugs, except for a concern with the TEE. We are also transitioning, as you know, from TEE to TLD, and we are running a little bit short of TEE, and so we are addressing that issue. But as I say, it's just unfolding challenges now, especially under the lockdown, and on a daily basis we are addressing those challenges. Thank you.
Great, thank you. And next week we are going to have one of the focuses for this webinar will be drug procurement, and we'll have Dr. Tong Minier from USAID and some of the other PEPFAR headquarters supply chain experts with us next week. I'm going to get, I may be being overly optimistic, but I'm going to give Clarata one more try. Clarata, can you, is your mic working? Okay, no, okay, so that's strike three. So let's, I did want to ask for one other comment before we go to the questions, and we'll try to hear from Zimbabwe and perhaps Uganda next week. Bactrin, did you want to maybe update us from your perspective?
Hello, good afternoon, good morning, good evening. This is Bactrin from ITPC. Yeah, thanks for putting this together, Miriam. We've personally learned quite a lot. So I'm going to share two thoughts from society and also from recipients of care perspectives. The first is clearly the great, most of the successes that we are seeing now in multiple countries have mostly been around the awareness building and knowledge built around the disease itself and possible interventions. I can tell you that most of the people on the ground are pretty much experts now on what to do, although of course behavior change takes quite a bit of time. We are seeing people flouting the rules, not taking the pieces of information seriously. So what really is going to work is a continued sustained provision of pieces of information, old, new, that needs to be drummed into people's minds to influence behavior change. We at ITPC have put together some materials that we've shared amongst our partners and especially groups of people living with HIV and other key pops to share the real facts about what COVID-19 is all about and how to intervene and how to actually be part and parcel of problem solving. We've encouraged people in these communities to be part of various task forces that are going on, that are asking, because some of the decisions initially that were being made were top down, but now there is, at least in Kenya, there is more involvement of these communities in trying to figure out the best ways to communicate the best strategies. And so we continue to get feedback and information from the ground and feed it into relevant bodies, just so that as we try to sort out all this, we also don't forget that there are other diseases that exist that need intervention. Otherwise, we will end up having multiple public health crises. The second quick comment is around monitoring of how well or how badly we are, doing as a country. We at ITPC are thinking of using our CTO model, as Anne mentioned, to look at stockouts of various commodities, etc., but also pay attention to satisfaction of recipients of care. What are people experiencing with regard to various other comorbidities? And so hopefully we may have something coming out soon that we shall share in this forum. So those are my two quick comments. With regard to the cards, I think while we take that model, or while we adapt that model, I think we also may need to educate the various players in that model for safety purposes, so that they're not exposed, and they also don't become folks who get to also endanger their group members.
Yep, so that's a great point, and it leads to a couple of questions that were in the chat box. So Helen Bygrave and Hervé, I think, both asked of Kenya, but this may be a broader question about whether there have been modifications in CAGs. So have they stopped meeting in the community, or are they meeting but just social 2 meters apart? Are they screening for suspect cases within the CAG, sort of self-screening, or any of those changes? Again, that could be for Kate, or for Bactrin, or for really anyone who wants to volunteer, if there have been changes in the way that CAGs are being implemented in your countries. Kate, you're off mute, but we can't hear you, so I don't know if you're trying to talk or not.
Miriam, you can hear me?
Yes. Yes, please go ahead. I think the internet is not being our friend today. So Kate, you could type your answer in the chat box, or we can come back to you when your line is clearer. Lee, did you want to make some brief comments from the perspective of the Global Fund?
Thank you very much, Miriam. And indeed, I would like to say a few things. Thank you everybody on the call, and thanks for organizing this. It's very timely and needed. I will send everybody a link on the chat that has the guidance for the Global Fund. Please read it, please distribute it widely. The Global Fund, in the same way in which we tried to be swift and agile when we responded to Ebola, we're also trying now to be swift and agile when we're responding to COVID-19. At the moment, 31 countries and 2 multi-country grants were able to reprogram some of their funds towards COVID-19 responses. The document I send is the guidelines on really what are the eligible activities. And let me just start by saying, if the grant or the Global Fund grant has some savings, those savings can easily and quickly be reprogrammed for COVID-19 responsibilities. If that is not the case, the existing grant funds up to 5% of the total value can be mobilized to be used, redeployed for COVID-19. That includes epidemic preparedness, lab testing, sample transport, surveillance, infection control, and that includes all infection control materials, and information campaigns. I know that some countries, especially in lower income countries, have requested for nutritional support and cash transfer. We are still looking into those, but for all the other activities, the reprogramming can quickly and easily be deployed. In the meanwhile, we are really following our global colleagues and our global level guidance from WHO, UNAIDS, IS, and all of your guidance on what needs to be really reprogrammed on the ongoing grants as it relates to TB, HIV, and malaria service delivery. Malaria and TB teams have already created a rapid task force. The HIV task force is coming online, and that task force will look into programmatic guidance together with WHO and other partners and UNAIDS, PEPFAR and others, but also responding to emergency situation relating to Wave 2 applications. Just to update everyone, Wave 1 closed last week. We had 57 countries registering interest to apply. Only 6 didn't apply. So 51 applications was received, including Uganda and Zimbabwe, Nigeria and Haiti. There were only 7 slippages, but we are expecting that due to lockdown across the world, that CCM application processes might be delayed and might not function optimally. That means that we need to be at the Global Fund together with partners more responsive, and we're discussing at the moment with the board options on what does that mean. I will update you in the next webinar as well. Thank you very much.
Thanks, Lee. And we also need to add you, I think, to our WhatsApp groups if you're not there already. So in the text, in the chat box, Clarata said that they're in Zimbabwe, they're giving guidance to promote and strengthen CARGs, that's the CAGs in Zimbabwe, but they're not meeting in the community, they're not meeting as groups. So one going to the health facility to but then they're distributing it to their colleagues in the CARG individually. I did want to, we only have 5 more minutes, but there's so many people with so much information on this call that I wanted to ask Ireneo Gaspar to give us an update from Mozambique. And while that is going on, if you have questions or suggestions about topics or things that you would like us to address in next week's webinar or in the WhatsApp group in the interim, just put them in the chat box. Ireneo, what's happening in Mozambique?
So for us, it's similar to what Zimbabwe is. We are shifting, we are prioritizing the 3MMD and the CAGs. Mm-hmm. So we have, we lowered the time in ART to be people. We lowered to 3 months, and without doing the CD4 or virus. The only big criteria is if the field and 6 months. Same for the CACs, the same is doing. The patient, the recipient of care comes to the health facility if he all the
Okay, so in both Zimbabwe and Mozambique, they are continuing CAGs, but not having meet-in groups in the community. Excellent. Okay. So we haven't addressed all of the questions. I think I'll just sort of, I'm not sure there are answers to a couple of these questions. So I just want to sort of signal boost them. So there are a couple of calls to consider multi-month dispensing for family planning. Helen is suggesting that this might be an opportunity for us to offer LARC, long-acting contraceptives, and push for those commodities and potentially deliver family planning commodities through community delivery. There are a couple of other questions which I'm going to bump to our WhatsApp group. So we'll ask Kate and Kenya about a little bit more about the mass testing. David Allen had a question also about, both David Allen and Peter had questions about the practical implementation of physical distancing or AKA social distancing. So we'll come back to those topics. There's also a question about, in addition to modifying existing CAGs, is there a possibility to create sort of new urgent CAGs? I think that is going to be a great idea in some contexts. And there are going to be a lot of challenges in terms of sort of, building boats as we're sailing them, changing the way we deliver services and responding to an epidemic at the same time. So for people on the call or for your colleagues, if you're thinking of introducing new models, if you're moving to a 6-MMD model, we have lessons from countries that have already been doing it, like Ethiopia. If you're thinking about initiating CAGs for the first time or expanding CAGs, there's a lot of toolkits and resources, both on the differentiatedservicedelivery.org website, on the CQUIN website, and really just amongst the people in this group. So we're at the hour. So I am gonna, I realize everybody is very busy and we are going to conclude. Thank you for putting up with our inevitable internet access issues and our change in lineup. But I do want this to stay an informal, demand-driven conversation. So we will reconvene next week at this time. We will have our usual 24/7 exchange by WhatsApp, and we'll continue to put resources in the Dropbox on the CQUIN website and share them with anyone who needs them. So thank you all for your attention, and let us know how we can help.